So I just went through our public meeting spiel that we do every time, and wanted to go ahead and start calling the roll. Jason? Is Jason here? Okay. Jeff Davis?
Here, thank you.
Kim Howe?
Good afternoon, everyone.
Kristen Henry told me she might be a little bit late, so I'm not sure if she's on yet.
I made it. Good afternoon.
Cool. Hi. Deborah Hoffine?
Good afternoon.
Debbie Jenkins? Okay. Willie Jones?
Good afternoon.
Kim Kelly?
I'm here.
Teresa Cobelt? Okay. Pete Moore? Teresa has just come in. I see her now. Rivo Murnix? Julie Short? Janet Stefan?
Hello.
Hi. All right. Bethany Toledo? Teresa, we called roll, but here we see you now. Welcome. Gary Tonks?
I'm here.
Nate Turner? I saw Nate come in. I wonder if he went back out. Jason Umstadt?
It's Nathan. I'm here. Sorry. Took me a second to get unmuted.
That's okay, Nate. Obviously, I was talking for a while and not knowing it either. So, Jason, are you in? Are you on?
Yes, I'm here.
Hi, Jason. Renee Wood?
I am here.
Hi, Renee. And I think I saw Pete come in since I started calling the roll.
Yes, I'm here.
Hi, Pete. Okay, we're going to go ahead and get started. A reminder that we are a public meeting and that we do welcome guests. Our guest policy is that you can listen, but not participate unless for some reason we're asking you for some specific information. We're going to start off with welcome and updates. We're then going to have an update on technology, on our marketing effort. There is one addition to the agenda since it went out, and we're going to get a brief update on the RFP and rate model process from Deborah Hoffine. And then we are hoping to have time at the end to do sort of a member round robin and go around and let people have an opportunity to share anything they've got going on in the workforce arena or anything where they might need help or assistance or want to make a proposal. So that's our agenda for the day. Let me start off by turning it over to Jeff Davis.
Thank you, Jackie. I want to thank you for still inviting me. So this is, mine is a welcome. I'm excited about the conversation about technology. I'm really happy Brian Hart is here with us from LAD. I've had some of the best conversations really that I have had in the past 10 to 15, 20 years with Brian and his team at LAD about what they're doing and how they're doing it and where the system can go, and ultimately will go. So I'm looking quite forward to that. I don't know, Jackie, if I know Jeremiah's with us and maybe we just take a moment. We didn't have the, ARPA dollars on there, but we may have a bit of an update. My guess is many people know, but it is moving its way through the legislature. And I don't know if Jeremiah, you want to give a quick update on that.
Yeah, thanks, Director. Yeah, so if folks haven't seen, so yesterday in Senate Finance Committee, House Bill 169 was amended. Basically, the language is stripped out and then a bunch of language is added in that has to do with just a considerable amount of federal dollars, not just ARPA, but other federal relief packages that were still out there. And so this bill appropriates a lot of those dollars. So we expect that bill to be voted on today. in the Senate floor, and then later today or tomorrow, concurrence in the House. So really quick, added in, this was the administration working with the legislator to appropriate those dollars. So what you'll see from us, primarily for this group, is some of the provider relief payments that we've been talking about. So this has both HCBS and ICF payments in there. And again, this is expansive across all HCBS. This will kind of mirror what you've seen in the CMS plan that we've submitted. This is just the provider relief payments, though. That's important to know. We don't have CMS approval for the plan, but this is just related to the provider relief payments. So the rest of the plan and the work that we've been doing, negotiating with a lot of you and working with the administration, those will still need to be appropriated later through a different vehicle. But this is the intent here, is to get out those initial provider relief payments as soon as possible. So that bill should get wrapped up this week, should get signed really quickly. And then we'll have to kind of continue to push CMS to get approval for at least that portion of the plan.
Hey, Jeremiah, this is Gary. So we've heard 10%, but I'm getting calls from families saying 10% of what on the provider relief? Is it so many months, 12 months? What is the?
Yeah, so what we've generally based this off of is 10% of annual revenue. So there you'll see kind of we'll have to work out further details, some things through Appendix K, some things through emergency rule, and then certainly communicating, what span are we looking at? And Debbie has her hand up so she can correct where I've just overstepped or misstepped.
You didn't do either. You didn't overstep or misstep. I was just going to say the time period we are submitting to CMS is claims for services delivered November 1st, 2020 through October 31st, 2021. Is that what everybody wanted to know?
Yeah, that's great. Thank you.
Yeah, thanks, Jeremiah. Okay, Jackie, that's all I got.
Hey.
Thank you.
Can I just ask a real quick question, Jeremiah? I noticed there was also 100 million appropriated for DoDD. Was that for the increased 6.2% FMAP for the first quarter of 2022? Okay.
Yep.
That's what I thought it was, but I just want to make sure. Thanks. Jackie, we can't hear you.
Boy, you think I would get this straight, guys. I apologize. We're not going to move on to technology then, and we have Brian Hart and Stacy Collins. I'm not sure how the two of you want to tag team who wants to go first, but you're going to lead us in the conversation around technology and what's happening.
I am happy to allow Brian to go first. He's just got wonderful things to share.
And I was about to say, Stacy, I will gladly go first if you want me to. So I am really excited. I'm going to start off by somewhat apologizing if I start to lose out on my voice. You do everything you can not to catch COVID, and then you still catch it. So I think I'm almost on the way out because I can actually speak today, so that's good. But if I just lose it completely, I apologize. So, but I do want to share just some slides and give an idea about what LAD is doing around technology and around really how we are trying to change the way that we deliver services. So I'm hoping this slideshow pops up well for you guys. Someone, if it doesn't, pop in and tell me it doesn't, because I can only see the one screen, of course. But what we are really trying to look at at LAD is how do we change the way in which we deliver services, not just how do we add some technology to fill a gap, how do we solve for, tonight's problem, which is the problem that we're always trying to solve for, how do we solve for all those different areas. And what we have put together is a model that we are calling beyond the concept phase. And one of the things that why we got to that is Oh, and then I just lost everything. Okay. That clearly didn't work to share my screen, I guess. Let me try again. My PowerPoint just completely closed, but I'll keep talking. Is we looked around the system and we saw there are a lot of areas where we think we can be more efficient in areas around how do we deliver services, how do we change the way that we staff different sites? How do we change the way that we provide technology-based services? And so we looked at, instead of just saying, how do we add things in, how do we change our system? And what that got us to was using technology in a different way than we had used technology before, and really in a way that I think a lot of people have used technology. And the idea being that we want to use technology first as the way that we deliver services. So changing the mindset of, okay, we have technology and we'll use it if we can find a place for it, and really looking at, let's use technology to start with. Let's say that we're going to start with technology as the main delivery method, and then anywhere where technology doesn't fit in, then we'll add in supports by in-person supports. And so one of the questions we get asked all the time, and Stacy, you're the only one I can see. Can you give me a thumbs up if you can see a slide or not? Okay, great, thanks. Why are we doing this? And as you look at these areas, and usually when I start with a group, I lay out all the reasons of here's why we're doing this. Now, knowing that we're in a crisis task force meeting, we know why we're in this. So these are all the reasons of why we did it. So here is the reason why we're going through it. And the time is, we can't wait. So we can't say, let's give it a couple years and see what's going on. Let's make changes now. So even before COVID, we were starting to look at this, knowing that the system we have is not sustainable with the staff that we have. And so our methodology is to look at smart living and forever home. And so smart living is our method of using technology as the way we deliver services from the first methodology, saying we look at all the things that a person has, solve with technology first, and then add in supports as needed. And then the other area is what we call forever home, and that's being able to use community-based settings. So either in small single-family homes, apartments, people in their family home, and using technology there as well, and geographical clusters to deliver services more efficiently. And what got us to this is, as we were looking at all the different ways we deliver services, we found there's a lot of time where our staff are just kind of sitting around waiting for things to happen. And we thought, how can we be better and more efficient in the way we deliver services so that people aren't just waiting for things to happen? And so our pilot that we're a little over a year into is a 3-year using smart home technology, wearable technology, that when someone leaves the home, the technology goes with them. How do we phase staff out? And not phasing out so we reduce staff altogether, but changing the way that we have staff. So instead of having 8 to 5 and the staff are just there and whatever happens they have to deal with, and then 5 to 2, whatever happens during that time they have to deal with that, but changing it in a way where we pull staff out of those block scheduling, replace those staff with remote and technology enabled supports. And then anytime staff come into the home, they're providing a value add intervention. And then again, with Forever Homes, our community clusters. So homes in walkable neighborhoods, we know that helps solve with transportation. If the neighborhood has sidewalks that actually lead somewhere, if they're close enough to each other. So if we need something, we can get someone there. And then really looking at how do we move away from just having staff there, and that's the outcome, that as long as staff are in the home, we've done our service, to what are the things that we want to actually achieve? How do we look at the individual's goals and outcomes and actually help them achieve them? Our outcomes that we have is we are doing a project with ourselves and with Xavier University, and we've added a few other tech companies as part of this as well as we've gone on, to give us publishable research on what technology investments work, what have the best ROI, how does this impact independence, how does this change the way we fund services, how do we look at bringing more people off the wait list, all these different things. And then an alternative service model. You know, we know that not everyone's going to get services. Not everyone's going to get a waiver. How do we provide services for maybe those who don't? Maybe is there a private pay method? Can we reduce the cost of overall services to provide for more as well? Now, in terms of technology, the thing that I get asked all the time is, where do we start? Is there technology for all of these things? Or we have all these complex needs, there's not technology that exists. And so we looked at, with an OT from Xavier, all of the needs that somebody has to basically live independently. We found that there's 308 things that we identified in a person's day they have to live independently. Those are our total requirements. And then we found there's 174 items that are really must-have requirements. Those are things that if we don't have a solution for those, we really can't provide a technology-enabled support. Now, as we went through and looked at this list, we looked at all the different technology that's out there, and we found that out of our total requirements, meaning everything somebody needs to live independently, 89% of those things have a technology-based solution. Out of those must-have requirements, again, the 174 that we have, 99% of those have a technology solution that we've looked at, we've vetted, we've tested, and it works. That last 1%, it's not that they don't have a solution that exists out there, because honestly, there's a tech solution for almost anything. What it means is that we haven't fully vetted it out to make sure that it's safe all the time. So those are things that we're still working on in terms of medication dispensing, fall detection, and some of those wearables that go out in the community. Now, I do have some really exciting news in that over the last year, we have worked really closely with companies like Black & Decker, Stanley Health, Foresight, Awake Labs, Priya, these companies, and we're finding good solutions for this last 1%. In so much so that around medication dispensing, we've spent the last 6 months working very closely with Black & Decker on developing a medication dispensing device that is specific for our population. So no longer do we have to say, well, this one's on the market. It was developed for someone who actually doesn't have a disability and doesn't need it, or someone in aging, and we're going to try to pigeonhole it into disability. We're looking at how do we drive that conversation straight to disability. Once we find that out, then what we do is when we have our list of all of our technology solutions, then we start looking at what are the different areas in which we can support the individuals. So how do we make sure that we're fitting the right person with the right solutions? And so with each individual, we have an assessment tool that we go through, again, partnered with people in our field that are experts in disability services, partner with experts in the OT field from Xavier University, and experts in the technology field to say, with this assessment tool, how do we know what people actually need? And this gives us a way to look at someone's needs, the things that are important to them, important for them, what do they want to be fully independent, and then how do we discover what technology works? So this is a screenshot that I pulled of one individual that we serve. And as we went through our assessment tool, these are the different things that this person needs to be independent. So, I mean, there are 6 things just around communication, 2 around external monitoring, 16 around routines, 3 around health, 15 around home automation to help him live independently in his home without staff. And as we go through this, what we found is that one solution or one package does not work for everybody. It has to be catered to the individual, to the situation. The other thing that we found is that it was really difficult to start connecting these dots together. So when you think about all the different technology that exists, when we first started this project in 2018, we found that, yeah, there's technology for everything, but how do you make it work together? So if you have Samsung devices and Apple devices and things that you've built on your own and things with database management and health devices and sensors and all these things, but all of them are done by different companies and none of them have an incentive to work together. We've spent the last couple of years working with these companies to start connecting these dots. And so now our staff that are working in this field are able to use these sensors, use these tools to not wait for staff to need to intervene, but to be able to actually provide support to the individual in their home so that we are there providing the same level of support we believe we would have if we were in the home. And once we solved for the technology side, then we saw, well, now I need a whole new staffing model, because no longer are we having staff just show up and wait in the house for things to happen, because the technology handles all of that, waiting for all the what if scenarios or well, we have staff there just in case. All of that can now be handled through technology. Now what do we do? And that's where we bring in all of the other areas of staffing, where we look at eliminating the block time caregiving staff, because the remote and the technology knows supposed to take care of that. And then we look at anything that's not solved by technology. That's where our targeted supports are done. We've actually created a new position at LAD called our integrated support specialist. And their whole day is filled with looking at what are the needs of the individual that's not solved through technology? What are the outcomes they're trying to get to be independent and fully inclusive of their community? And then what do they need? How can we provide better support? So is it through physical drop-ins? Is it through virtual care? Is it through connecting them with neighborhood solutions? And they specialize in these areas that they're passionate about to help provide the best support. And then what that allows us to do is all the time that's provided by this staff are value added. It also adds for a reduction in staffing need. So when you think about providing the remote support, those have large ratios of what you can provide remote support to. When you take away having one person for one staff member for one person, or one staff member for 4 people, just waiting for things to happen, and you change that to the remote support staff and tech-enabled support staff doing that, it starts freeing people up. And to give you an example, in Anderson Township, one of our Cincinnati suburbs, we have a cluster of 3 homes, and typically for our round-the-clock care in those 3 homes, we would probably need anywhere between 16 and 18 staff to hire to run that service. Using this model, we have our remote support that's providing to them, plus a whole bunch of other people. And then for our in-person interventions, we only had to hire 5 people to provide those supports. And you think about where we could use those other people, because going through your head right now, you're probably thinking of all the individuals where this system would not work for. You're thinking, well, it doesn't work for this person, it wouldn't work for this group. And you're right, it doesn't. Our evaluation, we've noted that easily 20% of what LAD serves could fit into this model. Probably 40 to 45% is the ceiling of what we could provide. But then what this does allow for is all those people that were providing inefficient or unneeded staffing needs just because we were waiting for things to happen, we can use them in those areas of higher need, allowing us to provide more service but not have to hire more staff. And so we've been able to actually increase the number of people we're serving without hiring more staff to provide that service. Now, our smart living pilot focuses really in 3 main areas. We have our Heights Smart Living Home, and anyone that wants to ever come down and see it, like I said, it's in the Cincinnati area in the suburb. It has hundreds of pieces of technology in it because that's our incubator. That's where we find out what works. Then we also are testing wearable technology to find out what works so that when someone leaves the home, the technology goes with them. And then how do we use remote and technology-enabled support to provide the same level or better service we would have if we had people in the home. Once we combine all these things and found what works, then we scaled it out to all the other areas that we're working in. So some of the things that we found out of our home and our successes is after a year into the pilot, for the 4 guys that are living there, we've reduced over 100 hours per week of direct staff service. So it's scheduled block time service. Going from, the 168 hours a week, they're getting less than 40 hours a week because they have all the other supports through technology and remotes that are providing that service. As we've expanded this out to other sites, we're finding very similar things. Maybe not as quite 100 in all settings because this was a very specific group, but really significant hours per week savings in each area. Also, we're continuing to do our study with Xavier. They're looking at, again, technology and level of independence. And we're finding really significant growth in people's independence as we remove the staff that are there. Staff are bored. When we've set up a solution where there's nothing for them to do, they start doing things on behalf of people because they want to be helpful. And so pulling that away helps people be more independent. Some of our successes that I want to really just quickly go into is how this is actually working. So our wearable technology is helping with a lot of our transportation issues, and even in a big city where we're at, there's still transportation barriers. And so using wearable technology is helping people ride typical transportation or be more accessible in walking their community for the first time. Smart Refrigerator, which was part of our Innovative Tech Solution Grant last year, is helping people be more independent in their meal planning. So they're planning their own meals, they're planning their own recipes based on their specific health needs and interventions. They order their own groceries. They either have them ready for pickup or delivered. It walks them through cooking their food. It knows what's in there. It knows what's expired. We can look into that fridge at any time and see if they need groceries. That alone helps people be way more independent in the skill around their healthy eating and their meal planning. But also that device alone saves anywhere between 10 and 15 hours a week in direct staff time. You think about all the time staff spends just around that, huge savings where you can use it somewhere else. Again, not to say that we're going to eliminate staff, but we're just going to use them more efficiently and in better ways. Another one is when you think about maybe not super smart technology, is a smart shoe insole. And this is one that we had an individual who, he had for the first 50 or so years of his life has always had someone with him when he was living in his parents' home, going to school, in services, because he was someone who was tagged as someone who wanders away or who tries to run away. And when we started looking at the reason behind why people are given this designation, we find that a lot of times it's because we haven't really dug into why. And we found with this individual, he just really likes to go on walks alone. And 2 things happen. He gets lost a lot, or sometimes he wanders into areas where he maybe shouldn't be. And so to prevent that, we just said, well, you have to have a staff with you, eyes on you all the time. We thought through technology, we could potentially give him more independence. So we tried smartwatches, which didn't work. We tried phones, which he would lose or break. And so we found this smart shoe insole, which is a little chip that goes in your shoe. All he has to do at night is put his shoe on a little base that charges it every night. And for the first time in his life, he's going on walks independently. If he doesn't come back within a prescribed time, we can send staff out to connect with him and find him. If he goes into a certain area where he's not supposed to go, because it's not safe for him or safe for those around him, it would alert staff as well. And this is what we're looking at. Not only does it help us with the cost savings, not only does it help us reduce the staffing needs, but it really helps us give people more independence. Now, where are there gaps? There are still some huge gaps. One, around transportation. We're still trying to figure out how do we solve for all the transportation needs of the individuals and give them the things they need. But then how do we look at smart ways around that? Could we look into autonomous vehicles? Could we look into smart scheduling around that? I talked about integration of platform and customization of needs. We can only go so far in what we do, but then buy-in. Thankfully, in Ohio, we have pretty strong buy-in from DODD, from our counties, from the parents, but we're still trying to get full buy-in in that area. And then how do we scale it? Forever Home is the way that we've decided to scale it, through community-based clusters, finding close proximity to each other, changing the way we do shifting of technology and staffing, and then looking at how do we make sure that we're just doing value-add interventions at all time to make sure that we're not just waiting for things to happen, but we're actually being there to impact the individual, to help them take control of their life and do the things that they want to do. And then when you think about what are those value-add supports that I talk about, here's an example of, for a lot of individuals, these are the 10 things that we find more often than not. So as we use technology to solve for all those other areas, here are the things that we still have staff doing. So they're still helping with these areas. And would we reduce some of these? Yeah, potentially sometimes, but in most cases, these are the things that we really need to keep focusing on with the individuals that we serve. The last thing that I want to share is LAD. We are preparing to put together, and we're working really closely with Xavier, with Dodd, internally with some tech companies, to give a smart living toolkit as well that would allow for us to take the knowledge that we've learned and share it with others. Because at the end of the day, we really love working down in Hamilton County, and we have no plans to expand out of there. But we know that what works well for us needs to be working well in other areas as well. So we're going to keep sharing information about what we're doing, how to share it with other people, and how to grow this model to other individuals as they look at ways they can grow through technology and through different models of staffing to help solve for the staffing crisis. Again, using smart homes that have either home-based technology, remote-based technology, different things like that. Community clusters and wearable is really the model that we look at that's going to help us provide a different level of support for the individuals that we're working on. So thank you for letting me share. Since I wanted to make sure Stacy had time as well, I was able to compress my, anyone that knows me, I can talk for 5 minutes or 5 hours. So I did my half hour, and we'll now hand the time back over to you, Stacy.
Oops. Brian, before you leave, we do have a couple of questions in the chat.
Oh, yeah.
So the first question, and some of these you may have touched on since they were put in, but the first question came from Renee, and she asked, what about hands-on things like bathing? Is there technology for that?
So there are, and so things like bathing, we found there are smart faucets. There are things there. I mean, there's an Alexa-enabled shower controls and bath controls. Our population, like I said, we don't serve anyone that needs hand-on bathing. What we know is that for those that would need that level of care, we can't provide a technology replacement solution for. Any area that we're finding efficiencies in our staffing, we can move that staff away. So, I mean, I went to a home last week before I was sick, and the staff, one of them was working on anatomy homework and one was literally cleaning. And there was one individual who was watching a movie in his room and one that was outside playing some game with a neighbor in the back. And I thought, why do we have two staff here? They do not need to be here. And so these are the areas in which we're trying to find these efficiencies, knowing that there's probably someone we serve who does need that higher level of care. We want to put the staff where they need to be, because that's such a limited resource. We're not going to, I think I've heard in meetings with this group before, we don't have a magic recruiting solution to get out of this. We need to also be more efficient in our staffing.
You also have a question here from Kim. She was asking about clustering homes. Is there a limit as to the number of homes or apartments you can have in the cluster so it does not promote segregation from the community at large?
So I should explain, our clusters of homes are all within 5 minutes driving of each other. So we don't have anything on the same street or in the same cul-de-sac or on the same block. They're all within 5 minutes of driving with each other. That way, that's what we consider a cluster. That way we make sure that people are fully inclusive of their community. Even when we have the opportunity to buy houses next door to each other, we don't. We pass those opportunities to make sure people are not segregated, that they're more separated out and inclusive in their community.
There's also a question, I think also from Kim. She wanted to know if the medication dispenser works for all types of medications like liquid, pills, capsules.
So the first one that we worked with Black & Decker only did pills or capsules. The one that we've worked on over the last year, the new version that we should have, they're going to send us the actual prototypes in the new year to start trying and testing out in our population. And we found that they can do ointments, they could do a liquid medication based on the system where it's set up. Now, again, it won't be a solid fit for everybody. If you have an auto inject insulin medication, that could work for you. If you have to draw and we need staff to draw an insulin, that might not work. And again, not finding a solution for everybody, but finding the best way. And I've already committed to Dodd and them and the rest of the team that once we have this prototype and we find that it's working, we will share it out and make sure that we connect with everybody, because we spent years trying to find a really great medication dispensing product and haven't found one that we think really solves a lot of areas.
So I have a quick follow-up.
Yeah.
Is there a limit to the number of medications that can be utilized by this device?
So it's based on doses. So depending on the size of the medication, obviously, and how many. So if someone takes 17 giant pills 7 times a day, the device may need to be filled once a week. If they take
so
once
I'm
or twice
talking
a
about
day.
I'm talking about if you have like 9 medications.
Oh, yeah.
Okay.
The dispenser we have now, dispenses. I think one guy is using it for 6 different medications at once.
Okay. That was my question, because I know, like, my son in particular is on 9 different medications a day.
Yep. And this may or may not work for him. I know nothing on the market right now works for someone with 9 medications.
Yeah, I know. Thank you.
You bet.
Any other questions from the group before Stacy starts her presentation?
Gary and Teresa both have their hands up.
Yes, I see that now. Gary?
Yeah, thanks for explaining your definition of cluster. There's a major discussion going on throughout the country, the ARC is nationwide, of what clusters and community means, because disability communities are springing up all over the country. And what we found historically, we've been around for 70 years, is that first generation is wonderful. The homes are new. The founders, both parents and staff, are new. They get it. But we've experienced this in our own housing corporations. The houses begin to deteriorate, and neighborhoods that were once good are not good anymore. The founders are someone else's mother or grandparent. So we're just cautioning everyone, you've got a good model. But I would just stress, we have to define cluster. Thank you for some of the questions, because it means different things to different people. And again, it's great that first generation, but the second generation and third, which happens in 10 to 15 years, can be devastating to people with disabilities if they're stuck in neighborhoods or in homes or with leadership that doesn't remember why we did this. And 10 years goes fast.
Definitely agree, Gary. And one of the things that we've done is we have a separate housing core that's specifically for this and looks to that future. So our housing plan right now is about 25 years from today that we're looking at, and ensuring that it's not just, we don't define what's a good neighborhood and a bad neighborhood, because there's people with disabilities that need services in every neighborhood. And so we want to be able to provide these services no matter, and we provide them throughout. And so that's how we defined it, is we didn't define it by how many homes are next to each other, but by a geographical location.
And Brian, this is Teresa. My question was more about, you had talked about your assessment process. And if I'm understanding correctly, you did not start with a wearable and assess whether the person would like benefit from the wearable or could use the wearable, or you didn't start with the refrigerator and figure out if somebody would benefit from the refrigerator. You didn't start with the technology
We
solution.
start with the person. We
Yeah.
always start, our focus is the individual. So we look at the individual's needs, and then we look at what solutions do we have that would fit those needs. And we find that we might think it's good, and each person is different. So we have kind of, even when you think of wearable, I think we have a bucket of wearables that we have. I mean, I know with smart toothbrushes, we tried 32 of them to get to the one that we think is best, but it might not work for everybody, so we could try a different one. So we start, it's very focused on the individual first, then finding the tech that works for them.
Thanks.
You bet.
I see. Is there anybody else's hand up or anybody else has a question? All right, Brian, we might loop back to you as we keep going, but Stacy, would you
I'll
like
stay on and listen. You bet.
That'd be great. Thank you.
Hi, everyone. And if I can, Jackie, I'd actually like to pass it over to Director Davis to get us started on the technology presentation. So Director Davis, I'm going to pass it over to you, and I'm going to get my screen up and shared for everybody.
Stacy, thank you. And Brian, that was fantastic. So I appreciate it so very much. And you're going to be working with us a little bit on grants, right? I mean, we've got partnership developing where you'll be available and you'll help guide us through these next months and years, right? I'm going to take that as a yes. All right, Stacy, let's see if we got if we can get that up. And I think Brian hit the high notes, right? Because he talked about it on the ground. So how do we move these discussions forward? You know, I think many of you have a sense of that, but you know, for what it's worth, I mean, this is how I see it. You know, as we sort of follow along with technology and how we're seeing it, I'm seeing more independence and autonomy. And I've said this now publicly a couple of times or more, but with that comes control, a shifting of control, you know, from our system professionals to the individual. And with that shifting of control comes with, you know, that pride and dignity. And I mean pride in a good way, and the dignity that comes with it. And we're seeing it every day. And I feel that we're, you know, on the verge of this system is of loosening its bounds a little bit and really finding ways to transfer control of one's life as much as possible over to the individuals we support. And so it makes me pretty ecstatic. And I think technology is clearly one of the primary ways in which we do that. Hence, you've seen over the last, you know, few months. And if you're questioning, I can't believe anybody on the call is questioning, why are we talking about this today on a workforce call? Well, I think Brian laid that out. And you don't do this primarily because of the workforce challenge. You do it for individuals, and the residual effect, as Brian said, is that you can better use that scarce resource and at the same time highlighting the individual and the individual's own accomplishment and autonomy. It's pretty exciting. Actually, it's more exciting than most everything I've seen in my 30 years. So I'm excited about it. We've begun to put in place some things that nudges and or forces these kinds of discussions to happen. So you'll see the technology first rule out and filed here at the first of the year. And that is designed really, again, to, when we say technology first, we mean to have those discussions for them to happen. And as we learn, because those discussions are happening, you know, I suspect most of it will be patterned after what Brian is learning. You start with the individual, but you have to start and you have to figure out how to do that. So we are trying to make sure that we have, you know, the proper vendor capacity to support, you know, the efforts that will go forward. We have a rapid response app out there so that we can we can connect county boards and providers and technology vendors immediately. I mean, that's really the goal. So as you can envision a future, or if you have a workforce challenge or whatever it might be, with the, you know, then let's get those conversations happening. Now that I think about this, because I got going, because I do have passionate about this. I might have stolen some of Stacy's presentation. Is that right? That would be rude. And then, of course, on-site on-call has been a piece of this puzzle for some time, and so now we're going to have an app out there that people can use to really work through. Will it be consistent, really consistent across the state of Ohio? Make it easier to make some determinations. All right. And then ultimately, I suspect, I trust Kim will reinforce this, but it is because it's a journey, it'll be one where there'll be continual adaptations and, modifications, and what we learn, we'll try and do better at. But I don't know. I hope that conveyed what my thoughts are. Stacy, was that a good segue or not?
Did a wonderful job. Absolutely. Didn't steal anything, did great. I know the director wanted to provide an update about the technology first rule, an update about the rapid response system. Just wanting to add in here about the rapid response system. We did our third training yesterday. We're putting out a recorded training for anybody on demand to access the rapid response system, know how to log in, know how to use it. So far, have had one request come in and 4 vendor responses. And so we're, thank you to Licking County, we're kind of watching how that's going. And then I expect here over the next couple of days, we'll see more of those requests come in once users are getting into the system, getting comfortable. And then we are also working on making sure, we want to talk with our ICF teams and stakeholders and representatives to identify if this is a system that can be helpful to them as well, to connect with technology companies. So that's the rapid response system. And then I know the director, you asked me to talk a little bit about the innovative technology projects that we have going on, and just to provide a little update on that. So I just wanted to update you all on what's happening there. So, and I know the director and Brian mentioned the work that they're doing under those grants, but the first is we wanted to update you about some pilots going across the state on what's called a TEMI robot. And the TEMI robot is actually a robot that is being piloted in about 6 different settings right now across the state, from school settings to an employment setting to residential, ICF to a small residential home. Also working on trying to get it out into the community and some day service sites. And so we just had the kickoff less than a month ago, and getting those TEMIs to every location and getting it piloted. And I know that we hope to have some future stories to be able to share with you how that's going. Basically, the TEMI, it does not a robot that has arms and legs, but it is a robot that has a screen and wheels, and does have some capabilities for maneuvering through buildings, engaging with families and individuals, connecting. Again, it's really a social engagement navigation tool, and I know LAD will talk about it as well. They are using this technology as well and seeing what it can do, and even pushing it to its limits of using it outside in the community as well. And so we've got those, and we look forward to updating you about how those are going over the next several months. As Brian mentioned, they are working on 2 projects as well under the innovative technology work. One is, of course, what he talked to you about today. And the second one is around that wearable technology and making technology accessible outside of the home. And so really excited to be partnering with them and to be able to share that work with you around the how-to guide, as well as this how to make technology more accessible in the community. We also are working with On Scene Marketing. They are a company that has multiple different technology modules around transportation's one, money management, and really just kind of consumer, like client management of services and systems. And so they are working on piloting their technology with providers across the state, and enhancing the technology to make sure it is a useful tool for agencies and providers across Ohio. We're working with Rosemary Center around a technology grant as well. And what they're using the technology for is directly in relation to training their direct support professionals and how they can better support and use technology to support individuals with developmental disabilities. New Avenues to Independence is another project They are working specifically within their ICF and to really work one-on-one, starting with each person and identifying based on their needs, what technology can be incorporated into their service delivery. And so we're excited to tell you about that. Also, we will be releasing, again, the Icf Supportive Technology Rfp. We did have it posted originally, had great applicants. New Avenues to Independence was awarded, but we actually do have additional funding available, and we want to make sure that we're supporting and that we can support ICFs in exploring supportive technology. So we are working on revising the RFP just related to assets and equipment. It got a little bit in the way. And so we're working on revising that, and we'll be getting that reposted. So it'll be called the Icf Supportive Technology Project. So be on the lookout for that. It's our goal to make sure that we're having kickoff messages for all of you and then giving you guys regular updates in the field, regular updates about what's happening in each of those grants and what we're seeing, what's working, what are the challenges. Additionally, I just wanted to share with you the different training resources that we have available. One of our key goals is to make sure that we're building across our system the comfort level and the skill and knowledge around technology for families, for people, for our providers, for our county boards, for our ICFs. And so these are some of the different training resources and activities that we are working on across the state to really build that skill, to build really the comfort in understanding what technology is and what it can do. So we have the Ohio Tech Ambassadors Project. We have the Technology First Education Shift Project. The Tech Ambassadors, just so that you know, is focused on really peer-to-peer discussions around technology and being able to really expose and explore and just consult around what possibilities technology can have. This group will be enhancing, not only bringing on 5 additional tech ambassadors, but they'll be bringing on 2 additional focused on direct support professionals and a direct support professional tech ambassador, as well as a family tech ambassador. We also have the Shift Technology First project, just to let you know a little bit about this. This is our pre-developed courses around how to just incorporate technology into kind of a person's everyday. These training modules are geared towards direct support professionals. They're geared towards our kind of system SSAs and Qs, as well as agency leadership, whether county board, ICF, or provider. And so we do have these courses available for free to take the courses, and you could take any level. And so we'll make sure to get you this presentation because these are links, direct links to all of the information if you're interested in the Ohio Tech Ambassador and learning more. If you're interested in learning more about Shift, you can do that. We also have entered into a contract with Disability Cocoon for training and resource development, and are working to process through all of the available content and materials that we have available to us in Ohio. So we'll be releasing different trainings and resources around technology through Disability Cocoon. And then we do currently have up what's called a Supportive Tech Expert RFP. And it is looking for different supportive technology experts to come either from Ohio or to Ohio to really do some in-persons, virtual, and engagement sessions across the state with our multiple stakeholders. Really focused is the focus is on families. And so that RFP is up on the Ohio Buys site, and proposals are due on January 1st of next year. And so we're really happy to be able to share these resources, share these tools, get feedback from all of you. And so wanted to make sure to share that with you. And then the next item is really, as we talk about outcome, like our goals, like what are our goals around technology? And so not only is it to make sure that we are innovating technology, we're trying to build skill and comfort around technology, but also kind of what are our goals within our service system? And that's one thing that we wanted to talk with all of you today is about, one of our goals around remote supports and assistive technology. And so I'm here today to talk with you and propose a goal your way, show some data on where we are today in regards to services and get your feedback. So right now, as we look at assistive technology and we look at remote supports, we are looking at a goal that 20% of our home and community-based services and residential supports will be assistive tech or remote supports. And so where are we today? And so as I look at and we talk about this goal again, we're wanting to have a discussion with you. We are wanting to get your feedback on it. Wanted to show you where we are currently in our services and where our numbers are and how we've been looking within those services over time. And so this gives you a breakdown, of course, of kind of some key services and how those services have looked over time. So you're going to see residential services here, and I'm going to go over what falls into this. RS is remote supports. The yellow is the adult day array, and this teal is the respite. You can see in 2019, assistive technology is now in the tracking as well when that service became available. So AT is assistive tech, and you can look at this over time. So as we look at this actual graph, our residential services, so what's pulled into this number is a couple different things. One, our adult family living, shared living, HPC. We did include, for these reasons, on-site on-call only from claims. We know it's not inclusive of everyone. Adult foster care, participant-directed goods and services, HPC transportation, and community inclusion. So in the adult day array, if you're questioning, is our adult day support services, career planning, group employment, individual employment supports, vocab. But for our goal, we are looking at this residential services number and kind of how we compare with remote supports and assistive tech. So in regards to calculations and kind of trying to identify where we are today, we did combine residential support, or remote supports and residential services together. So for 2018, there is at this moment potential duplication in these numbers as we continue to refine the goal with you, as we continue to refine the data behind the scenes. But right now we are looking at about 1% in 2018 was remote supports. When we look at the number in 2019, it was around 6% of residential services was remote supports and assistive tech. In 2020, that number is 8%, and then 2021, it was 7%. And so again, we need to continue to refine the data, the logic behind the scenes, but wanted to talk with you today about your thoughts about the goal and propose that your way. So thank you. That's all I had, but we're curious on getting your feedback. Mm-hmm.
Sorry, what do those numbers represent? Are those the number of people receiving those services? And if somebody receives multiple services, are they counted twice?
So within this actual graph for you today, this great question, Debbie, is people. And there is, in the numbers I'm showing you today, absolutely the potential for duplication. And what we would be working on is reducing that duplication and, of course, creating some logic behind the scenes so that we can get an unduplicated count. But this today absolutely can be a duplicated count.
Stacey, there's also a question in the chat room from Kim. What if you identify assistive tech or remote supports that can be used by a specific consumer? Will it be required or optional for that consumer to switch from a DSP?
So as you look at the employment first rule, at this point, there is no requirement that somebody switch from a DSP to just technology. The priority of the employment technology first rule is to really have a conversation with each individual and their families to explore how technology solutions can be helpful for people, to try out that technology and to build everybody's comfort in it. But there is nothing in our rule, Kim, at this point around requiring it. Wonderful question. knowing where we are now, again, knowing that this could be a duplicated number, is there concerns with the 20% target?
Stacy, did you say when you wanted to reach that 20% by?
That's part of the ask as well, is in regards to the number. How are you guys feeling about it? We did not put a date in here, but was curious on what your thoughts were of what was possible.
I guess, Stacy, my thoughts are, and this is just initial reaction. One, I think it depends on how you're going to count and measure things. We have some people who are going to need some of those other services as well as the assistive technology and remote supports. I apologize, I'm getting a lot of feedback. So I think we've got to figure out how we're going to define it. Are we going to look at the total population and then just look at how many people are receiving that as part of the supports, or are you really looking at people who transition to no longer receiving some of those other supports and only fully look at assistive technology and remote supports? I think 20% would be a challenge if you're looking at that, just based on people who would only be receiving those, versus if you're looking at how can we look at a person's day and maybe a piece or part of that, or some of that might be able to be transitioned into some technology and supports. I think we could do more of that than looking at transitioning people completely away from other services and into just those.
Debbie, thank you. Teresa, or Renee, actually, can I go to Renee first? I think Renee's had hers up. Go ahead, Renee.
I like to build on what Debbie just said about how much remote support is being count. I think it should count by the hours that it reduces direct care from a person. Like if it reduces 2 hours a day, you could count it. But if you got the same amount of hours a day, but you got Alexa in the house, that shouldn't count. Does that make sense?
I was cutting out a little bit on my end. I'm not sure if I'm having technical difficulties, but I think, Renee, it's around looking at, and tell me if I'm getting it right, around looking at the amount of remote support somebody's receiving in the day, really evaluating that.
And if it cuts down the hours, if it doesn't cut down the hours of needing a person, just because you got something in the house that helps you should not count. Does that make sense?
It does make sense, absolutely. I know that we've started to try to dig through that data to identify and see if somebody is starting, remote support service, how does that impact any other type of residential services that they're receiving? But there is a lot of work on the data side that we need to do, but we can continue to work on digging through it. I know we've had some conversations and just trying to understand too, from LAD's perspective, what's happening on your side. So Brian, thank you for sharing that. But yes, it does make sense. And Renee, hopefully I've got it all. I'm understanding it correctly. You can tell me if I'm not.
Yeah, you got it.
Thank you. Thank you. Teresa?
Thanks, Stacy. There might be a question in here for Brian too. I'm curious. So I admit that I am not intimately involved or wasn't involved with the development of the technology first rule. And so, but I feel like when I read that, that's slightly different than this, which is slightly different than the AT or remote monitoring rules. And so what I'm trying to figure out in my mind kind of, so for example, maybe the question for Brian, some of the things that you've been doing or delivering, have they been billable as AT? Or, I mean, we've had traditionally problems with things like iPads that would be a technology solution. And for some people, I mean, that's been a challenge maybe at times to get paid for through Medicaid. So I guess I'm trying to figure out how all the pieces and parts are working together to meet that goal, if how we're going to be measuring it is in essence 2 billable services. And there might be other things that would help you meet your goal of technology first, but aren't billable. I feel like that was a lot of words. I don't know if the concept is clear, but.
I do. I think okay. I can definitely speak to this now that I'm fully back unmuted and my camera's back on. But so we have worked really closely with our county board. So I don't know if there's anyone on here from Hamilton County DDS, but worked really closely with them about, as we were developing, what technology we use, why are we using it, what's the importance of it. And so we have not had issues really with that. I mean, I'm sure there have been times where we have to provide more justification than we think should be needed, because there's almost no justification needed for me to throw a body in a room and just hope that that makes everything work. And so trying to change that mindset at our county level. And so I don't know if that's, we don't work in other counties, so I don't know if county by county, if that's an issue, but we have had very little resistance to get this done, especially, and then going from the county level of it, then go to the Dodds level, we've had nothing but, open arms to have us try new things, see if things work. Now, there are areas of technology where we have not attempted to bill for it because we're still in a learning phase. So we have not billed for any kind of medication dispenser because, like I said, we don't think we have the best product yet. And so we're still using it in a very specific pilot-based trial model. Now, once we have all of our data, and again, everything we do is data-driven, then we would go and we would ask, for reimbursement on that, and I think that would be fine. But the idea is making sure that we have the right piece of technology and then it's person-centered, that it's not, in our mind, again, the technology is not to just have an add-on to something else, but really is to provide a meaningful outcome. So we haven't had that issue. I'm going to knock on wood because maybe we'll have one tonight. But so far, at least in what we've done with Hamilton County and with Dodd, we've had really good success. And usually a lot of the issue that we found is educating the SSAs, because this is very new for them and we get it. And, as new as it is for us and we're ingrained, it's new for them. So when we get pushback from them, there's a little bit of education that usually has to go on. But once we get through that education piece, then they're usually it's not a problem.
And I would just add, Teresa, like there are situations that I feel like are happening kind of on the daily where there is either questions around technology, how it can be incorporated, like maybe inconsistencies in, county board wants it, how is it going to be reimbursed? But Debbie's team, Nyoka and Kelly, have been, providing technical assistance as quickly as possible and trying to figure out where we have flexibility, where we don't from a, waiver reimbursement standpoint. I know that they're working and trying to have conversations with ODM about ICF and what does it look like in technology there. And so I know that there is definitely a commitment to try to work out those kinks, because there are absolutely kinks that do exist, and they're trying to find where they are and how to make it work. And then trying to get out guidance and how it can be utilized, or if it can't and why. And then how do we then look at ways to potentially make it work? So there is definitely still, I don't know how to say it, activity where it's not fitting completely well together, but we're trying to work it out as quickly as possible.
And just one thing I want to add, and feel free to cut me off and tell me to stop talking, is we are spending a lot of time speaking in other jurisdictions, so with other states across the country, other service sectors, and from a provider standpoint, we see so much more willingness to find solutions, whereas in most states, they're like, well, it just doesn't work, try something, go away or try something else. And so my advice is, if you get questions, ask, and if the answer is no, find out why not and find a different, a way to do it, because the willingness is definitely there, I think.
So Pete has his hand up, and then we have a couple of questions in the chat box. Pete?
Can I respond? I think
Oh, I'm
Renee's
sorry. Go
question
ahead.
maybe is to me, which is, so Renee asks, are you saying it should be billable in order to be counted? I'm saying as the goal that Stacy has proposed, the only way to count it is if it's billable as one of those two services. So I'm not saying should or shouldn't. I just wanted to clarify that. So the proposed goal would require, the way to count that goal is those two billable services.
But the two billable services and we just, I think you should reduce the amount of hands-on services. For example, if I only need an Alexa in my home to remind me to take medication, or maybe remind me of something else, that's not going to be a billable service, but it's going to reduce staff in my home. So not everything, not every technology is going to be billable. And I just think the more independent the makes the individual and the less staff in the home should count for that. I know you guys can't see me, so I don't know if I'm making sense or not.
You're absolutely making sense to me. It just brings the question about, and we can have this at another time too, is how do we get that information? Because right now what we have access to, the information we can pull from and look at is the actual Medicaid claims data, authorization data, claims data. And so we don't have access to some of those other data sets that would help us get to that number. So, but yes, absolutely, Renee, thank you.
Stacy, would it be possible for county boards to help with some of that data collection that Renee's talking about? I mean, it would have to come from the bottom up from SSA teams, but I think they could do it.
Yeah, I think Teresa just put it in the chat. I mean, I envision probably something in the future around collecting information through the Ohio ISP. And so I do wonder if there are some opportunities there. Nate and Teresa, I would say the same. Absolutely. And it's now included, as Lori said in the chat, updated that Ohio's ISP to make sure technology was called throughout. So there's different aspects we could get the information from. So thanks.
I think Pete had his hand up.
Yeah, thanks, Jackie. I just want to, really congratulate and thank Brian and Ladd for all their work on this. It's truly amazing. I had the chance to spend the morning with Susan and Jason doing legislative visits and heard the spiel to some legislators, and they were certainly impressed with the progress you guys have made. I guess a comment for me in regards to any goals that are set is, sometimes things like this come up where I call them unicorns, where they're rare or do they really exist? And you guys have spent so much effort, working your way through this. And is it possible to get other providers to get to that level? And I think sometimes people look at the effort you put in and say, boy, this is just too much. I don't know if we can take this on or whatever. I think in order to reach any goals, there's going to have to be a massive education effort around this and building the trust of the people we support and families and providers to say, it's okay to try this and there's safeguards in place. I just think there's like an invisible fence when it comes to technology. And we look at providers like Ladd saying, geez, I don't know if we could ever do that, but you can try little things and little things can make a difference. The data that Susan reported this morning, just saving an hour a week of the human resource and how that adds up to big savings is pretty remarkable. So I just think with any goal around this area, we're going to just have to educate our butts off and continue to encourage pilot projects and share as much as we can. So that's my 2 cents.
Thank you.
Does anyone else have a question or comment?
Have we made any progress on the timeline, or are we still discussing that?
I think it's still open.
Because I think we've gotten, what, 7-8% in about 4 or 5 years? So to think that we could get, do we anticipate needing another 4 years to more than double what we've gotten?
It's a great question. Nate, sorry, it took me a minute to get caught back up to the timeline. It was.
It was more sort of rhetorical and thinking. I wasn't asking.
I think technology is moving pretty fast. And now that we got all this effort behind it, I think it's doable, I really do. And I think that the younger people are really going to gravitate to it because younger people know a lot about technology, so they're really going to gravitate to it. So I don't think it will take that long to get to 20%.
I
Any
missed it,
other
Renee. What
thoughts
was
on the
the
deadline?
length of time? Sorry, Jackie.
No, I think we both said the same thing at the same time there, Stacey. Okay.
I think I agree with Renee in that I think a lot of people are gravitating toward technology. I mean, I think at least we have a reasonable shot to at least double what we've gotten in 3 to 4 years. Whether we're going to be at 20%, I don't know, but I think if we say 4 years, it would give us something to shoot for, and hopefully we'll land amongst the stars.
And I want to just chime in as a provider. The first step is getting over that first hurdle of a few people. And then once you build in that technology, it really could grow exponentially. So I think, honestly, I would be shocked if it takes 4 years, just based on the growth that I'm seeing it happen in our agency, but with other agencies who are reaching out to us about it as well.
That's what I was thinking. It's not going to take 4 years.
So it sounds like consensus is saying it should be faster than 4 years.
And sorry, Teresa, it took me just a minute to get my screen to actually share. So hopefully you all are seeing the data.
Yeah, so, and part of the reason I asked Stacey thinks is just, so I was trying to figure out like, what is 20%? Like, do we mean, so I know these are bar charts, but if it was a pie chart, are you thinking that one distinct slice of the pie, a quarter of the pie or a fifth of the pie would
So what we
be-
were throwing out is that we would combine, like, so your denominator would be
Thank you.
every person in residential services, we would include the people in remote supports and assistive tech, right? So that would be our bottom, our denominator number. And then the top would be the combination unduplicated of the people in remote supports and assistive tech, that we wouldn't be looking at just one, that we would be combining it together because if you're using one piece of assistive technology in your home, or you're using 5 through remote supports, you would still be part of that count because you're incorporating technology into your residential services. So that's what we were thinking about as the initial start.
So how you just said it, I feel like is different maybe than how it's worded, which I liked how you said who are incorporating technology in their residential supports, because that does suggest, it's, somebody had said, like, it's not an either or an only, but 20% of people are incorporating residential support or technology in their residential supports. I don't know, maybe that's exactly what you said initially, but it felt different to me when you said it that time.
I was really challenged with, like, how do I write it? So yes, I think I can definitely, we can work on rewording it and seeing how that feels, because it truly is. How do we get to 20% of people are incorporating and using remote supports or assistive technology in the residential services? So thank you. We'll work on the actual wording of the goal.
And you have a few people in the chat room encouraging us to make it a 2022 goal, that given the staffing crisis, that the push needs to be aggressive.
Okay.
Any other points, any other questions for either Stacy or Brian?
Yeah, I was trying to type this in the chat, but I couldn't do it fast enough. Anyway, I think it should be a 20% reduction in human resources because of technology. In other words, it can't just, we need to define what we're talking about. Instead of just saying technology like remote support assistive technology, everybody could have something in their home by that time, but we need to define it more. What are we talking about?
Okay.
So you could have 80% of people have some kind of technology in their home, but that's not what we're talking about.
We can definitely, Renee, ensure that we work on the definitions of the technology and what we're talking about falling under remote supports and assistive tech to help kind of clarify what that goal's tracking.
Okay. Anything else anybody wants to add or ask? Stacy, did you get the feedback you needed?
I absolutely did. Thank you, everyone, for your feedback and working this through with us. And Brian, thank you for being here to present all the great work you guys are doing at LAD.
Gosh, thanks so much for having me, you guys. Appreciate the work you guys are doing to help us get through whatever we want to call whatever comes after a crisis with the staffing. So thank you.
Thank you, Brian. We have a few minutes left, and what we wanted to do was open it up for a quick round robin, and I can go ahead and call on people one by one to make sure everyone has an opportunity. And if you want to pass, you can absolutely feel free to pass. But we wanted to know if anyone had something they wanted to report out on, if you had any subcommittees or proposals that you were thinking about, any inquiries at all. We just wanted to give everyone a minute to say anything they wanted to say to keep our work moving forward. So just to be a little different, how about we start at the bottom of the alphabet and work our way back up this time? So Renee, that first, is there anything you would like to share or again, you can add?
Yeah, I was talking to Katie Hunt Thomas yesterday from the Delivery Center. And I can't remember what state is doing this, but there's a state that has a legislative seat only for direct care workers, and they have a minimum wage a minimum wage for that care worker, so you can't pay them under a certain amount. And that would include agencies. So I just thought, wow, that is a wonderful idea. But I wish I could remember what state. I'll find out though.
Okay, I've got that. You know what, Renee, when you brought that up, it reminded me that I skipped over Debbie talking to us about rate models. So before we finish the round robin, and thanks for making me think of that, Renee, Deborah Hoffman was going to give us a quick update on the model and rates.
Actually, not so much rate models and that sort of thing. Kim had asked me to let folks know that we are currently working on the language, the outline of the language to go into the RFP that we're going to use to get us a vendor, a contractor, to help us with the simplification efforts around our waivers. So around looking at the AAI and the DDP and how we establish spending limits and all of that sort of thing. And so I was just going to let folks know we are, like I said, starting to work on the outline. We're hoping to have a good solid foundation around that language early next year. So sometime in early to mid-January. I have still been talking to legal about how public of a process the actual development of the RFP can be, because there have to be non-disclosure agreements and a whole lot of things that go with it when you develop an RFP. But there, I want to provide the assurance that once the RFP has been released and we have a vendor, there'll be a robust stakeholder process associated with all of the work that that vendor will be doing for us. So work around the AAI, the DDP, the sustainability work that Clay spends time with the counties on, 5-year projections, all of that financial stuff that goes into supporting our waivers. There'll be, like I said, a very, very active and robust and aggressive stakeholder process around that. But the actual development of the RFP is a very different process. And so that's what Kim asked me to let folks know, that that work is underway and there'll be more to come soon. Which rate model, Teresa?
So I told Jack, I asked this question. I feel like a broken record. Way back at the beginning of this work task force, we had pulled together those subcommittees, and one of the things that we talked about were long-term solutions and short-term solutions, and that we have not revisited our rate model for HPC, for example, for a very long time, and that it didn't. We talked about the ideas of, could it somehow include in the rate model differentiation for specialty staff or staff with different levels of experience? Could it include EREs, all that kind of stuff? And we were told at that time that it was going to be part of an RFP.
Yeah, all of that work is included in what we're talking about.
Okay.
We really are talking about the entire system. So looking at add-ons, are those appropriate? Does it make more sense to put them in the base model? The entire structure. So I guess when people say rate model, I'm like, well, we have a rate model, but yes, it's the entire structure is there for to be revisited. So absolutely, that will be part of it. And then of course, Stacy's got an RFP out that is specifically looking at service rates for the adult day array, and all of that will sort of come into play as part of how we establish waiver budgets. So I just wanted to make sure that rate work and this project are separate. Does that help? Okay.
Great, thank you, Deborah. And also real quick, before we turn back to everyone, we were going to get a quick update on another effort that this group had wanted to see happen, and that was marketing around DD professionals. Is Tamara still on?
Yes, I'm here.
The floor is yours.
Sorry about my lighting here. That's why I had my camera off. But no, just some real exciting stuff going on around the marketing efforts for direct care workers across the state of Ohio. So DODD has partnered with some other agents, other state agencies, Department of Health, Aging, Mental Health, and I think Departments of Veterans Affairs is coming in as well because all of us are experiencing that shortage around direct care workers. So right now we have contracted an agency to start the creative process and to begin working on some PSAs that will run, but it will go well beyond PSAs. It will also be something that will be around social media. You'll have your outdoor marketing, some radio, as well as your PSA commercials. So it's going to be a full-blown marketing campaign, which is very exciting. And the way that it's set up now, we're looking at running that over the next year. So it'll be a 12-month campaign, not just something that's short and quick, but a 12-month campaign that will really drive people to Ohio Means Jobs to apply for these jobs. Now, the thing that we're going to be asking everyone to help us with is to make sure those that are looking for work or that they have positions available. Yes, I'm sorry, I just saw something pop up. Yes, so we use the term direct care workers so that it would encompass DSPs, it would encompass nurses, it will encompass TPWs and our DCs and all of those at the same time because we're all having those same issues. So the campaign is very broad, but the pictures and things that you will see will capture all of our industries, especially DODD. So we're really looking forward to that. But again, what we will need help with is driving people to Ohio Means Job. There's going to be a special landing page that's just for direct care workers. And so we want to make sure that people who have positions available, that they have their profiles updated and that they're actually using Ohio Means Jobs to be able to put their positions, post their positions, because this whole campaign over the next 12 months will be pushing people to that website and we'll give them an opportunity to apply for jobs in their areas in all of our different fields and industries. So I just wanted to share that we will be asking your help in doing that, but it's going to be a great campaign. Health is running point on it. And as you know, they've done most of the ads for the state of Ohio around the coronavirus and things like that. So they're in depth and experts at this. So they're helping along and taking point on that.
Do you have a sense of when that campaign will launch?
So we are right now in the creative phase of it. We've just approved some concepts. There's still some things that need to be agreed upon, but it will be done in December for sure. So you'll see that over the next month launch. It would probably be the first of the year, but it will be created and ready to go by December.
Okay. Any questions?
Kim is asking if it's going to include nursing as well, Tamara.
Yeah, I saw her question pop up. So yes, that's one of the reasons we are saying direct care workers, but it will include those nurses, DSPs, if providers are looking for those, as well as TPWs and our DCs. All of those will be included in that, general direct care workers. But where the individuality comes is once they get to that landing page, they can actually pick and select things that are just for them. So if nurses are coming to there will be nurses positions there.
Okay. So part of our challenge as all the different folks here representing is to ensure that if you have available openings, they're posted.
Yes,
Okay.
and the way I believe it works, and I could be wrong, it's been a while since I looked at how it was that each, as a provider or as someone who's looking for help, you might have a profile. You need to make sure your profile is updated and that your positions are listed. And we've been working with JFS on that as well. So when I say this is an interagency effort, it truly is. Even people who are not soliciting for, positions or trying to get help, they are still helping this effort. So it's all hands on deck right now.
Okay. All right. That's good to know. Thank you for the update. All right. I'm looking at the time and it's 2:30. So I'm going to propose that we do an electronic round robin. If anyone has something underway, or like Renee's point where she said she's heard something in other states doing that we might want to explore, anything at all like that, if you guys could, you can post it to all of us or make sure that myself and Steve and Kim get it, and we'll get that in the hopper for our next meeting. So if that sounds okay to everyone, we'll go electronic. If you've got something you want to share or an idea you want to see pursued. Jeff, I'm not sure, is Jeff still on the call? If not, I'll throw it back to Kim. Our next meeting, by the way, is set for January 12th from 1 to 2:30 p.m. Now let me send it back to Kim.
It looks like Jeff had to go, so we're at our end of our time, so I'll just thank everyone for your energy and effort today, and we'll talk soon.